Hey, so welcome to this week's case. This week is a continuation of last week's case where a patient came in after delivering a baby. She was hypertensive with a headache, abdominal pain, and seeing flashes of light. Now, let's just summarize the case real quickly. She was 38 years old. She had an uncomplicated delivery and came in complaining of the following things. She had a severe headache a few days after with light flashes, abdominal pain that was localizable to the right upper quadrant. And on examination, she was hypertensive with a blood pressure of 180 over 115, and she was hyperreflexive and she had abdominal pain. Now, this was a case that was quickly recognized as being someone who was sick. A 12-lead ECG was done immediately, and we reviewed this last week. There was a right bundle branch block pattern with essentially the classic findings of wide QRS, the RSR prime pattern in V1, along with the slurred morphology in lead V6. So we saw that, and there's no real set classic, presentation on ECG in such patients. But let's talk about preeclampsia. What is the initial approach to a patient like this? And what is one of the biggest, most dreaded complications known as HELLP syndrome? So I think the most important takeaway in this case is really immediate and accurate recognition of a patient who is essentially pretty sick. And in this case, the patient was recognized as being sick, and everything was done initially and appropriately with blood pressure management being set up, blood pressure rechecks, OB/GYN is notified. The patient was set up for seizure precautions, placed on a monitor, given fluids, and they set up for medications. Now, what medications? Well, I think there are two basic camps. One is a hydralazine approach first, followed by labetalol, and then there's the labetalol group. And I tend to be in the labetalol group, but the hydralazine approach is just fine too, where you essentially double your dose of hydralazine from 5 to 10 to 20. And if that doesn't work, you may switch to labetalol, all while setting up an infusion of magnesium. And like I said, I like labetalol because it's simpler to me. It's doubling it from 20 to 40 to 80. And then if that doesn't work, switching over to hydralazine, and then setting the patient up for an infusion of magnesium. The two approaches are fairly similar. They work pretty quickly. The half-life is very similar for both medications, and the outcome is quite favorable. The question comes up is how much magnesium. Remember, preeclampsia is really dysfunction of the endothelial cells and a dysregulation of magnesium along with other organ systems. So magnesium is a key component in treating such patient, and she was hyperreflexive too. So how much magnesium? You give 1 to 2 grams initially, followed by doubling that, and you essentially give magnesium until you have loss of reflexes. So that's how you treat it. Now, this patient actually went on to have labs done, and the labs were significant for a hematocrit that was low to 28%, LFTs that were abnormal, LDH and platelets, they're all very, very abnormal. So she was accurately and correctly diagnosed as someone who had preeclampsia with the complication of HELLP syndrome. And just to kind of review this a little bit, there are many complications of preeclampsia in postpartum women, especially, and seizures, stroke, cardiac effects, cardiac dysfunction, kidney dysfunction, and HELLP syndrome are the biggest ones, I think, that are most concerning. Well, let's just touch base on a couple of these things, the cardiac effects and HELLP syndrome. And with regards to the cardiac effects, there are several different effects that such patients incur on the heart. As you can see, just remember that as you have this increased pressure on the heart, the RV, has increased pressure as it dilates. And remember that the right bundle branch actually lies in the interventricular septum there. So when you have pressure building up in the RV, you're going to have a lot of strain and stretch put on that right bundle, giving you the pattern we saw in this patient, a right bundle branch block pattern that may be completely reversible once she's managed correctly. So HELLP syndrome, it's a terrible complication with a significant mortality, and it really stands for hemolysis, elevated liver enzymes, and low platelets. There is a classification for this that's not that important, except to know that when you see a patient that has these parameters that are off, you should be very concerned that they have a significantly higher chance of doing poorly. The prevalence is somewhere between 0.5 to 0.9%. 70% of patients, 70% of patients have this in the third trimester, and the remainder in the postpartum period. And the most likely time for patients to actually have this is in the immediate postpartum period. But just don't forget that this can occur at any time after 20 weeks of gestation, and it's quite rare before 20 weeks. So like I said before, recognition is absolutely key in the correct management of such cases. And during pregnancy, the gold standard, the best treatment is to deliver the baby itself. And in the postpartum period, you just have to aggressively control that blood pressure. So remember, the mortality rate is high. It ranges anywhere between 0 to 24%. And lastly, don't forget that the perinatal death rate is high. It's 37%. So once again, recognition is key. Management using something like a checklist approach is really beneficial. So that's it for this week, guys. Thanks so much. Until next week, take care.